everybody. My name is Soumya Mandava, and welcome to the What the Health podcast, brought to you by the Alumni Association in conjunction with the Renaissance School of Medicine. Each episode, we bring on an outstanding alumnus who tells us what the health we can expect after graduating from medical school. From their journey to their interests to incorporating it into their chosen fields, we get to hear it all. So, let's jump right in.
Hi, everyone, and welcome to our new episode of What the Health. Our co-host is...
Hey, everyone. My name is Mit. I'm going to co-host today, and I'm a first-year medical student.
And today we have the distinct pleasure of talking with Dr. Pan. She's the Division Chief of Geriatrics and Palliative Care at NYP Queens, and she's the DIO for Graduate Medical Education, as well as a graduate of the class of 1992 from Stony Brook. How are you doing today, Dr. Pan?
Great, thank you.
We are so happy to have you here today. Just to kick things off, can you tell us a little bit about yourself?
Yeah, I'm Asian American. I was born in Taiwan, and I happened to grow up in South America because my father was a diplomat. So I grew up there throughout my elementary and part of junior high school. And then I came to the US during 7th grade. I didn't speak any English, so I had a really rough time catching up. They told me I was the most quiet girl in the whole world. And I really had to kind of integrate my kind of Chinese upbringing, which is far more conservative and respectful, with the American kind of everything's out there, that kind of thing. Don't raise your hand, just speak up, that kind of culture. And then once I graduated from high school in Brooklyn, I went to Harvard for my undergrad, which was really rewarding. And then actually took a year off to just explore other careers, and then ended up going back to Stony Brook for medical school because I think medicine is really, something that was meant for me. And then after that, I did my primary care internal medicine residency in Rochester, New York, followed by a fellowship in geriatrics back at Harvard because I miss Boston so much. And then went to Mount Sinai for my first faculty job. It was an academic medical center. I did a lot with both geriatrics and palliative care, which was really just a very new field at that point. And I worked basically at this point in an inpatient setting, ambulatory care setting, nursing home setting, home hospice care, and just a lot of different experiences because I like variety.
Thanks, Dr. Pan. One of the things that you mentioned is that you took a year off in between. Could you tell us a little bit more about what you were exploring during that time?
Yeah, so I had a little bit of doubt because I didn't always want to be a doctor. I came across medicine because when I was in high school, one day my dad just came to me and said, hey, you have to think about what you want to do when you grow up. And I was like, grow up? And he was like, yeah, do you want to be a doctor or a lawyer? And the conversation kind of ended there. So I was like, well, I don't want to be a lawyer, so I guess I'd be able to be a doctor. So I went into pre-med and everything. So even though I had a lot of friends who had, I was like, I better just put on the brakes and just see if there's anything else. So I worked in an import-export company that was a Japanese firm. I dabbled in real estate. I dabbled in baking. I thought about maybe I would open my own bakery business, but in the end, I kind of decided that I would come back into medicine. And when I was telling my boss from the Japanese firm that I was leaving, I pulled him aside and I said, oh, can I tell you something? He goes, oh my God, are you pregnant? So I was like, no, I'm leaving. I'm going to medical school.
It's such a great story. And I think a lot of our peers will love hearing sort of stories of the gap year. So just to hear a little bit more about your work, what does a day-to-day schedule look like for you?
Yeah, so day-to-day, every day is very different. So at this point, probably I spend 20-25% of my time seeing patients, doing inpatient geriatrics and palliative care consults in the hospital. Maybe another 20-25% doing teaching and curriculum development. And then another 50% administration between my division in geriatrics and palliative care, staffing, manpower, recruitment, that kind of issue. And then another significant part in managing the graduate medical education office. We have close to 200 house staff in various residencies and fellowships. And definitely throughout the pandemic, there's been a lot of ups and downs. So I pay a lot of attention to everyone's well-being and try to kind of just provide as much support as I can for our future physicians. So every day is different. I mean, I don't even know what's going on each day. If you ask me what's going on, I say, let me look at my device and then I'll know.
One of the interesting things that you mentioned is time dedicated to medical education. So could you tell us a little bit about how you got involved in that, and what role you have with it?
Yeah, I think medical education is really important. I've always been interested in it when I was at Mount Sinai, when that was my first faculty position. We were transitioning into Y2K. I don't know if you know what Y2K is. Uh, but it was basically going from 1999 into a new century, 2000. There was a lot of uncertainty and fears around, like, how the world will break down. Nothing really happened. But Mount Sinai was designing a Y2K curriculum for the medical students, and they wanted a lot more vertical and horizontal integration. So I was putting pieces of geriatrics and palliative care into year 1, year 2, year 3, throughout the years. The clinical years are obviously pretty self-explanatory, but I was able to put in some palliative care content into, let's say, year 1 anatomy, right? So how do you do that? And it was a debate about, well, is your anatomical cadaver your first patient? There's a big debate about that. And a lot of students do wonder about, who donated the body, and like, can we reach out to their families? And what are the ethics of that and the rules around that? And it ended up also having a ceremony, like a memorial service, to thank our cadavers for being there for our education. So I just always was interested. I did a lot with kind of fellowship development, integrating other stuff into residence. I was a geriatrics fellowship director at NYP Queens. So I just feel like it's very important to kind of give back to the future of medical training.
Yeah, thank you so much. It's really interesting. We at Stony Brook, one of our first writing assignments is sort of reflecting on our first patient, which we consider the anatomical cadaver. So it's interesting to see, the sort of background of the development that it took to sort of get that culture shift in schools.
Yeah.
I guess a question a bit about the field. How do you think the field of geriatrics is going to change in the future as the United States faces an aging population?
Yeah, so it's an aging population. Actually, many societies in the world are aging, except for the very, under-resourced, underdeveloped countries. And I feel like the US is behind on geriatrics, in that even though it's a field that's been there for a long time, there's a wonderful, rich resources and knowledge. From a payment standpoint, it's not as valued. So I think as a society, we're trying to fight that battle and not succumb to like the volume or the value type situation. Because, in the clinic, you can see a lot of patients, if they're young and they're college students, and they come in and they run out. But when you have geriatrics patients who can take maybe 10, 15 minutes just to walk into the exam room, you can't just limit a visit to 15 minutes. That's not fair to the physician, to the patient, anybody, right? And now I think a lot of people hear about patient-centered care, but it's, I think, more really about relationship-centered care. It's not only what the patient wants, it's not only what the doctor wants, it's about the relationship that they form, their ability to get to know each other, trust each other, and then be able to negotiate different goals and what's important. And to do that, you can't rush in and rush out. So I think that the system really needs to realize and support that for new patient visits, it has to be an hour. And for follow-up visits, it has to be 30, 45 minutes. It can't be like a rushing situation. So I think just from a system and reimbursement perspective, it really has to change.
I really like that term that you used, relationship-centered care. So that kind of leads me into the next question I wanted to ask you is, when you have to have conversations with patients about things like advanced directives, healthcare proxies, palliative care, hospice care. They're more sensitive and complex topics, but they're still things that need to be discussed. So how do you use the relationship you have with your patients to go into those conversations?
Yeah. So when I was doing my outpatient geriatrics practice, which I had to give up, unfortunately, because I have so many other things going on, but I knew my patients, and I think that's the best time to start a conversation and to just normalize it, to say, this is the time that we're giving out flu vaccines. So this is also the time of the year where we're going to go over advanced directives. Have you heard of the term? Do you have a healthcare proxy? Can we talk about that? And I think that because it can be a sensitive field, to make it routine is very important. And also to expect emotions, because you never really know which patients have had good experiences or bad experiences with that kind of thing. So we have to be personally prepared for any range of emotions and to acknowledge them. So if the patient becomes nervous or upset or something, we have to acknowledge it and say, wow, I'm really sorry, but it seems like my bringing this up really, upset you. Can you tell me more about that?
That sounds incredibly complex to navigate and something that really requires a lot of skill. One other question about you. Was there a particular moment when you knew that you wanted to go into this field, and a moment that you really felt excited about this?
Yeah, so after my internal medicine or during my internal medicine residency, I really was drawn to my elderly patients. And I guess it was at the point where nobody really realized what delirium was yet. So when my older hospitalized patients would become agitated or confused or something, I was taught as a resident to call a psychiatry consult. And of course, the psychiatrist would come and say, oh, rule out organic causes. This is not like a late life psychotic break. And then they would just, leave. So I'm like, oh, that didn't really go anywhere. So that made me become interested in getting a geriatrics fellowship for further training. I didn't mind change. A lot of people don't like change, but I was changing my residence every other year by moving all throughout South America. So when the hospital administration changes, everybody was like, oh my God, change, new person. I'm like, so you just keep on doing the work that you're doing. And I also like variety. So I knew I couldn't do the same thing every day. I needed some variety. So now what I do, I see patients probably 20% of the time at this point. I do teaching, maybe another 25%. I do a lot of administration, research, scholarly activity, quality improvement, probably 50-40%. So I really like that combination. And I feel like when one thing is not going well, like if I had a really challenging patient, I could go to like an academic thing that makes me really happy. Or if the paper that I'm writing is not working well, I go see a patient that's really rewarding. So I like that kind of, division. Plus, I was very, very close to my grandmother when I was growing up. She actually gave me my name, my Chinese name. It means happy heart. So I feel very blessed for that because I tend to be on the optimistic side. But I think that then I was interested in seeing elderly patients, making sure that they do okay in the hospital, that they receive treatments that are beneficial rather than harmful, that they don't stay in the hospital too long because other things can happen, and what is the best, safest way to get them back home with their loved ones. And then palliative care really started when I went to Mount Sinai. The whole field was just beginning. It wasn't like a known thing. And I had always been very interested in pain management. I never really got such good training, whether it's a medical school residency or a fellowship, actually. So when they were starting that, I got into it because I was interested in the pain management perspective. And it became this great thing because I wasn't afraid to ask my patients about pain anymore. I would be able to get that under control quickly. It was very rewarding. And then I learned that the really tough part is really kind of the goals of care and the communication and managing all the family disasters and dynamics and that kind of, the crisis situations.
So, Dr. Pan, you've been a part of this community since its early stages. How would you say that the last 2 years with the pandemic have changed palliative care and geriatric care?
I think it really brought out the importance of palliative care in terms of being able to talk about advanced directives in advance, not last minute. and that it made a lot of people realize that it's the skill that every frontline clinician needs to have. So we've been actually doing that kind of education for our interns, because interns always get sent in the room and say, oh, get the DNR, or, you start the conversation. And what training did they have? Is because the other people don't want to do it, right? So I think just by teaching that set of skills, we have a course called PALCOM, which is palliative communication skills. It really empowered the interns to be able to have that conversation even more so than their faculty attending physicians. So that's been like a really, really nice experience.
It's always such a pleasure when we get to interview one of our alum who's so impassioned about their field and is constantly making changes to make their field even better. So thank you so much for talking with us today, Dr. Pan. We really appreciate it. Thanks for tuning in to the What the Health podcast. Please be sure to check out our linked resources at the Stony Brook Medicine YouTube channel. See you next time.